Can we start, Chitrakala?
Yes, ma'am. We are live now.
Yeah. So, very good evening, one and all. Today we are starting with our scientific program as our international speaker has OT list scheduled. So, without wasting much time, I invite you all for the Seed to Bloom series, episode 2. And I hand over Supriya to introduce the chairpersons so that they can introduce the speaker and we can have the first talk by Dr. Kamal Oza. So, Chitrakala, just show the CVs of both the chairpersons. Yeah.
Good evening, everyone. And so, as Dr. Lakshmi Madam said, we are going to start this first session of the scientific. So, to chair the session, we have Dr. Ranjana Khanna from, she's president of Prayagraj. She is senior consultant and director, Ranjana Hospital, Prayagraj, national vice president, Foxy, 2017. She had been the founder president, Prayagraj chapter of ISOPAB, ICOG governing council member, and then president AOGS, honorary secretary AOGS, organizing chairperson of many national Foxy conferences like Obstetric Dilemma in Allahabad 2022, BOH in Delhi, and many more. So faculty at various national and international conferences and webinars. She had been the recipient of many national awards like Foxy Dheera Award in 2022, Foxy Dr. TK Tank Reproductive Health Care Promotion Trophy at AICOG 2015, and Foxy Smriti Milan Award, Save the Girl Child at 2013 AICOG. She had been felicitated for Safe Motherhood Committee at AICOG 2014, Public Awareness Committee, and many more, Oncology and Midlife Committee. She has been authored many articles and chapters in various books and journals. With these words, Madam, I request you to kindly introduce the speaker, and over to you, Madam.
Yeah, thank you so much. It gives me great pleasure today to introduce Dr. Kamal Ojha, and he is consultant gynecologist and honorary senior lecturer at St. George's Hospital, UK, medical director of Concept Fertility, member of the Royal College in 1995, special interest in infertility treatment, oocyte donation, and advanced ultrasound, has published extensively in national and international journals, as well as authoring chapters in textbooks, founder member of the International Society for the Fallopian Tube and Reproductive Surgery. He is an active member of the European Society for Human Fertility and Reproduction, ESHRE, the International Society of Ultrasound in OBS and Gynae, ISOG, and the British Fertility Society, BFS. Besides that, he's done his graduation very much in India in Kolkata, RG Kar Medical College, and he has done his post-graduation from the very famous BHU Varanasi. So we are just waiting to hear from you, Dr. Kamal, on poor ovarian reserve. Over to you.
Thank you very much. I'm just going to upload my slides.
Yes.
So I hope you can see the slides.
Yeah.
Yes,
we can.
Perfect. Yes.
Yeah.
Right. So once again, thank you so much for inviting me to give this talk. I'm sorry that I had to pick this time and be quick because I've got a busy clinical schedule today. It's a working day, but it's a beautiful sunny afternoon in London, and the weather is like around 18, 19 degrees, and it's sunny and it's beautiful, absolutely lovely. So why am I sitting here and giving a talk? I should be outside, but never mind. So low ovarian reserve, we see the situation all the time, and we would like to see how we deal with it. So let me put few question marks here as to what are we doing here? Why do we assess ovarian reserve? How do we assess it? And how do we identify low reserve? And how do we apply it in clinical practice? And then conclusion. So that's like the broad scheme of the talk today. So why do we assess ovarian reserve? Well, I think it's important that you look at this slide. I like this slide very much because it quickly tells you about the fertility of a woman. You can see how the reserve is so good, around about 36, 37, it starts going down. And if you look at the live birth rate, it is again going down as it ages. So assessing the reserve, this brilliant paper gives you a great idea about what the story is. I mean, people may quote high results and pregnancies after 42, 43, but in reality, this is real statistics, real data. Now, this is another fantastic slide, which I always like to look at. What is a good number? What is a good number which results in outbirths? Sankara's paper on human reproduction about the optimum number of eggs and live births. And you can see the graph in the left, it tapers and then it starts going down. So if you get more eggs, it goes down. If it's a very low number of eggs, the pregnancy rate, live birth rates are low. Now look at the second side of this slide. You can see how if you use donor eggs in somebody who's got low live birth rate, the pregnancy rates are higher, the live birth rates are higher. So it is the reserve that is the key. So that's why we assess it. And we are looking at reproductive aging. So let's go a little bit further on it. And here, I like this slide very much for clinical practice in gynecology. So look at this slide. It says the optimum fertility is between 20 and 30. Between 30 and 40, it starts to decline. And as you can see, between 40 and 45, the fertility is sort of going towards ending. And then the woman gets irregular cycles, and then she ends into menopause. So in one sort of slide, you can see the story is very clear regarding the whole woman's reproductive life. So it is so important that when we're seeing women, we know what's going on. When someone comes and tell me, oh, my cycles have become shorter, I say, her reserve is low. It's just a key to me to see, my God, I need to speed up here. Something might go wrong. So let's go further. And you can see now, what is the point? So you can see poor response, optimal response, and exaggerate. So it is important that once we analyze this reserve, how do we use it? We are predicting fertility, we're predicting poor response, we're predicting hyper response, and then we're making the individualized treatment protocol and dose. So the value of assessment is so important. There are other reasons. We use egg donors, we use women. A lot of women are coming to us for freezing their eggs now. So we need to see whether they've got good reserve to freeze their eggs. Otherwise, it doesn't make sense. Now, women who got cancer, they're going to go through chemotherapy, radiotherapy. Again, in fertility preservation of those cases, we have to assess reserve. And of course, the modern endoscopic surgeons doing operations on ovaries like endometriosis, they should assess the reserve before they operate and after they operate so that they can say what degree of damage there. So you can see how the story of predicting this reserve is so useful. How do we assess ovarian reserve? Well, let me talk a little bit about what are we assessing and how we're going to assess them. So you can look at this picture, you can see the follicles which have got antrum in it is the ones that we are trying to see. So antral follicles are between 0.25 to 4 on a biopsy, and the large antral follicles are between 4 to 10 millimeters. So if you're looking at reserve, the antral follicles of 2 to 8 millimeters is the one we're looking at. And your true reserve is in the ones in the primordial follicles. So if you got functional reserve is your antral follicle count. So there are two areas of it in reserve. So when we do ovarian biopsy for ovarian tissue freezing, it's the true reserve that we're looking at primordial follicles. But when we're clinically doing things, we're looking at functional reserve. Again, it is so important to understand what is happening hormonally in the whole story. And this paper, this particular paper, shows you where the AMH is working in the small preantral and the large preantral. And then you got your FSH coming in the picture, and then you got your inhibin B coming in the picture. So the story is similar. And once these follicles are growing, they're producing estrogen. So it is so important to understand the biochemical aspects of the biophysical changes that are happening in an ovary. And as I said, the outlines are clear, the AMH in the initial part, the AFC in the middle. The FSH story about reserve assessment is a big question mark nowadays. Not many people do that. I do it for hypogonadotrophic hypergonadism when there is completely lower. In those cases, it may be useful. It is widely used, the FSH, but then the reliability is low. And as we know that, so we don't do FSH a lot, but I do an FSH LH for patients who may be having very low reserve. Looking at ultrasound markers, I think, as I said earlier, if you look at volume, you look at your follicle count, and you look at blood flow. These are three things we look at for ovarian markers. And so I would say the volume has not shown huge amount, but you can sometimes, when you're scanning, you see the volume is small, you can say this reserve is going to be low as you're approaching towards menopause. If you have a young girl who has come to you into your clinic, who's 15, 16, 17, is having irregular periods, the way we assess polycystic ovary is by doing an abdominal scan and looking at the volume. So volume has got a role, but if you're being very precise, it may not be very useful. So antral follicles will be the ones that will be very, very useful. And I'll give you in the end of the lecture of what I take as antral follicle, but then the count is key there. And of course, the Dopplers, they haven't really shown a huge advantage, the Dopplers for reserve assessment. So the method should be for young doctors who are scanning, you should use a transvaginal probe, you should empty the bladder, you should identify the ovary and increase the depth, so increase the size of the ovary, and then slowly scroll through the ovary and look for follicles between 2 and 10. I go for 2 to 8 millimeters and look at these structures and do a total follicle count. So right side and left side, and then you add them, and that is your total antral follicle count. So, sorry. Again, you can do a 3D for antral follicle count. It is a good method, but you don't really need to do it. I use it for research purposes and to teach trainees, so we can do the antral follicle sitting with them and observing it. So it's not essential, but it's something that we may want to do. And again, these are methods. I'm going to skip them. This is from one of my colleagues who does solo ABC, which means like you color the small follicles, and then the machine, the software in the machine calculates the number of follicles there. So it is another way of doing it, where if you've got a large number of follicles, it's useful. Small number is not very useful. We don't use it in clinical practice. Again, there are questions about reproducibility. I'm not going to this today because there are so many things I'd like to cover. But I think the 2D and 3D has shown to be equally effective. So as I said earlier, I do 2D only in my clinical practice. And again, the validity, this is another paper that we have jointly published. And the volume with 3D is much better compared to volume with 2D. But overall, the volume has no huge value in assessing ovarian reserve, as I said earlier. So these are the publications of the volume, and you can see they're not hugely beneficial to show significance. Again, looking at Doppler. So the Dopplers, there are two types. One is the stromal flow. The ovary doesn't have a ovarian artery. So you can't do it like a renal artery or uterine artery. It has got stromal vessels. And for the 3D, we look at the whole volume and we see the network of vessels and the flow in it. So there are two different ways. So stromal flow for ovarian, and you see the vascular infusion flow and vascular flow index. These are three parameters for 3D. Again, these are done from different studies, and we have seen that they're not of much flow, but much value. So I would say I wouldn't do Dopplers for ovarian reserve. So various factors are taken, markers. You got age, of course. You got the basal FSH, you got the basal LH, you got estradiol, inhibin B. I would do AMH, and I'll do total antral follicle count. That's what I would say has shown the most benefit. And you can see the different publications and the different value of these are here on the right. So the two parameters which are most useful is on there. Again, many studies have shown this, so I'm just showing a few more evidences that has been published, which is shown, which is important for our young trainees to see that even something that has been shown to be beneficial, you should look at what is the evidence around showing the benefit. So the practice that you do is clinical practice and evidence-based practice. Again, here you can see comparing AFC and AMH, the graphs are going similar. So they're very close to each other. So you could do only AMH, only AFC, and you could be still fine. So I sort of, in principle, go for AFC, and the AMH is to supplement my results because the studies have shown that they're both very close to each other. And again, there are a few more studies that are there which shows response. So the important thing is that in higher AMH and higher AFC, you'll get an exaggerated response as hyperstimulation. Okay. And again, here you can see where you will say the reserve is poor. But when will you say the response is going to be poor? So if you look at the follicle count, if you say less than 4 or less than 6 or less than 9 or less than 10, so several studies have shown that if you do a follicle count which is less than 10, which is total follicle count, that is counted as low. So it could be 4 to 6 to 8 to 10. And that's a way of assessing by antral follicle count and saying this is going to be a poor response. Now, the nice guidelines which we follow in the UK is that if you got a follicle count of less than 4 or 4, that is a very poor ovarian reserve. In those cases, we will not be treating the patient. And we keep the AMH, which is done the way we do it, is less than 5. So again, these are parameters by which we decide patients will not be funded on the NHS. So it's such an important thing in women or couples who are coming for treatment in the UK as to what is the practice, what is low reserve, and when we will not treat patients because of the response and the success rates. Again, you can see here the diameter of the follicles that have been tested is 2 to 5, 2 to 10, 2 to 6, 2 to 8. Again, I would say we follow 2 to 8 millimeters, and that pretty much keeps us safe in not over predicting response. And again, here you can see how you can look at the specificity of these 3 or 4 parameters that have been used. So 10 millimeters is acceptable, but 2 to 8 millimeters is more valuable. So response prediction is very important. An antral follicle count can predict poor response and it can predict exaggerated response. And that is why the value of assessing ovarian response is so important. And if you look at your AMH again, less than 7 picomoles and more than 15 picomoles and more than 25 picomoles. So this is where you can see the assessment of AMH again can tell you which cases will be showing poor response. So the cutoff here is 5 where we don't treat, whereas 7 is taken as below 7 is taken as low. I know that the different ways of measuring AMH is there. So you can see in this graph, it is with the nanograms per ml. I think in India we use nanograms, so it's less than 1.4, 1.4 to 5.3, and then 5.3. So you can see the 3 groups where the different reserve is seen. And there is, if you compare the 2 groups of AMH and AFC, there could be a discordance. There could be a group where these results are not matching with each other, and there could be a difference in the response. So there will be situations where you might find that scenario. So one needs to be aware of that. So because sometimes you get an AFC which is low, but the AMH is high, and you get AMH which is low, but the AFC is high. Those discordances can be seen, but generally they're interchangeable response-wise. Now the question comes about AMH, where is there a variation within the cycle? So AMH is pretty much, standard. It doesn't change hugely during the cycle, and that's why it is far better than FSH, as we all know now. And that variation is very, very low. I've seen AMH in situations where there's hypergonadotrophic hypergonadism, where the AMH is low falsely. So there are very few situations where the AMH can be low, but in general, the AMH is pretty much static. And then, of course, the type of AMH you test. The first generation was the DSL, the immunotechnique, and then you got the Beckman-Coulter one. So you need to be aware of which method is being used in your center and see what their standardizations are. So the timing and then the technique of doing AMH. And so you can see here, again, this is in picomoles, which is what we use. In different age groups have shown different AMH levels. So you could say that 0.3 to 14.7 is normal for somebody who's 45 to 50 years of age, whereas between 20 and 29 is 13 to 53. So the age group variations can be there. Again, in principle, I will tell you what I use as a marker to explain patients, but this can be very confusing because somebody could be having a level of 5.5 and she's younger, and we say that reserve is low. Somebody may have 37 and it could be fine. So the variations with age can be difficult, but this has to be taken into account. And some of the reports that we get now in the UK, they show the range for their specific age group, and that helps us in assessing. So it is important that this system is taken into account. That is the Roche SA Elect system. Again, you can see this graph. This reminds me of the graph which Sankara published about number of eggs and live birth rate. You can see the AFC count, which is low, it's gradually rising, and then at a higher level, then it peaks there. So that is your number of eggs that are being retrieved is going to increase, and live birth rate increase from there. So you can see it's such a useful a graph to see. And if you look at, this is the one I'm talking about, Sankara's graph, you can compare the two. But if the egg count keeps on going, the live birth rate drops in the end. So the quality drops. And we know that. We've all seen that when somebody who's got 30, 40 eggs, the number of good quality embryos are much less. Again, this is a big chart showing the predictor of IVF outcome. And I will skip this one, but it just shows as the number of follicles are less, and as it increases, your live birth rate goes up. Okay, so we're talking about AMH here now, and again you can see that greater than 37, between 31 to 37, and less than 31, and your levels can show how we can predict live birth rate with the AMH. So prediction of live birth rate has been shown with AMH. So AFC and AMH alone, or in combination, have equivalent predictive accuracy. And if you look at AFC and AMH for oocyte quality, again, that has got limited prediction, but it's still a good marker. Whereas age is the best surrogate for marker. And there could be situations where there could be no proper correlation between the AMH and AFC in predicting ovarian reserve. So one needs to keep that in mind. How do you apply it in clinical practice? So FSH, now we don't do FSH in our clinical practice unless if required. However, in the NHS sector, if you're seeing patients in the NHS and the health service, FSH and LH is standard practice. The AMH is held back because of cost purposes. More and more clinics are using AMH now, but AMH is not standard everywhere. So we do antral follicle count and do FSH and LH, and we do a progesterone level on day 21. That is like the standard thing besides doing rubella and thyroid function and other tests. So AFC and AMH, they are the two standards, but it's not standard practice. A GP will be referring a patient, they can do FSH and LH from the practice, but they will not be doing AMH. So it has to come to a main center. And that's because of the cost implications. You know, it is, the NHS is a free service, and it has to be evaluated from cost effectiveness, and then the test is done. Again, if you look at how do we respond to the low AFC and the low AMH and the normal AFC and normal, and how much drugs we give them, how much medication we give them. So we all know now that there are two dose regimes we should be following. We should be following 150 units and 225 units. Giving more than that, there's debate about the usage. So what we have said is that if your reserve is good and the patient is young, we'll be giving between 150 and 225 units based on the BMI. So 150 is our standard. We'll give 225 units if the BMI is higher. But if you have got a patient who has got a lower reserve, then 225 or 300 units is what we'll be using for good response. And obviously, where the reserve is very high, you get higher OHSs. So you'll be mindful of that. You'll be giving a lower dose. So again, it is important to remember that dosage is based on the BMI and on the reserve that we assess. So the AFC count is 10 to 21. This is the dose is being used in most places. We have this has been published, and the evidence has been seen there. So if you're looking at AFC-based protocol, and you'll be using less than 10 follicles, that means 5 follicles in each ovary. You may use whatever method. You can use the antagonist, or you can use a long protocol. and the dosage will be 300. Occasionally we'll increase, but I would never increase more than 300 in my unit, but 300 is where the marker is. I know that people will be using 450 units. I'm not surprised some people use it, but most centers in the UK will be using 225 or 300 units. And you can do an agonist or antagonist. That is up to how you practice mainly. I do mainly antagonist cycles. If the follicle count is between 10 and 21, again, it's 225 units, you drop the dose. And if it's more than 21, you drop it to 112.5. You'll be using the recombinant versions to 150. And again, if it is polycystic ovarian syndrome, then we use antagonist and HMG 112.5 to 150. So you can see how the reserve, that is the antral follicle count, has just made me decide what is the dose and what is the drug use. You got to keep in mind the age, the BMI, and previous response. So these three factors will help you and decide how you vary your response. So if you've got a poor response previously, you may want to change the drug, or you may want to increase the dose if you use a lower dose. In the BMI, we tend to give them a slightly higher dose than what we give normally. And obviously with age, you've got to keep that in mind. Here you can see again, the response is sort of similar in both the population, the white population and Southeast Asian population. So it is not hugely different. And so for the data, the subjects we have used, I think it's important this slide to put across that women from Indian background or from Southeast Asian background, the response is not hugely different. Although the numbers were small in this group, there were 182 patients, but it didn't show much of a difference. And you can see that it's 25.4% to 26.4% is the live birth rate. Of course, in the Black Asian population, Black African, it was lower, but otherwise there wasn't much of a difference. And if you look at ethnicity as a determinant for ovarian reserve, in Spanish and Indian women, again, there was a difference in this study. There was 6 years of age difference in favor of Spanish. That means the reserve-wise, you can see the population was to 37 and 31, and that was a significant factor in the dosage they were using. So there are some studies which are showing difference, but I know that there are many publications in India which have shown that the AMH count is dropped. The reserve has dropped a lot for some reason, which I don't know we have answers for that, but that is something that we could discuss after the lecture. So, of course, when you are scanning and looking for antral follicle count, you can look at many other things. And you can see in this picture, when doing the antral follicle count, you can see pick up a polyp in the left picture. You can pick up a complete uterine septum. You can pick up a submucous type 0 fibroid. You can pick up hydrosalpinges, and you can pick up adhesions from previous surgery for Asherman. So the advantage of scan for AFC to me is a no-brainer. You should be using this method. And of course, you can pick up again endometriosis, and there's a video here which is not working. Okay. Okay. So where AMH and AFC is concerned, well, as I said, the AFC, as I said, it's simultaneous, it's in-house, it's readily available, it's reproducible, and there's a cycle variation to it. There can be, certain times the cycle, the follicle counts can be a little bit difficult to assess because of the presence of a corpus luteum. So if there is any concern, I would repeat them in a week's time. And quality control, well, it depends upon the person who's scanning and the resolution of the machine that you're using. And if you've got a cyst or a bees or poor image quality, then it can affect it. So I think the first two factors are very important. AMH, it's a simple blood test. It can be done even if a cyst or scan is not available and is reliable at any time of the cycle. So that's the key point difference. Well, if you take the sample, you should be careful how you take the sample and you prepare and you store it. There is inter-lab variations and the interpretation could be different. And there's no standardization across different centers. So one needs to be aware of these factors when you're assessing AMH. And I think in India, you may be having more experience about how the results vary from different places. So I would say the single best predictor is FSH for ovarian response, equivalent to the AMH. AFC is the best predictor, FSH is not. And the prognostic information on treatment outcome is also very good. The dose, the choice of protocol, and the outcome is best assessed. So, of course, inherent availability ultrasound machines is required, and it's not easy to perform by people who are not trained. But if you're trained and doing routine scans like gynecologists with fertility experience, is very easy. Here's the variability of AMH is low, so it's fine. And this is another intracycle variability of follicle count. And you can see, as I said earlier, the true reserve is primordial follicles, the primary, then the secondary, and then the antral follicles. That's the functional reserve we talked about. And then you got the dominance pattern. And obviously, as the true reserve, the AMH is coming from this pool of follicles, and therefore the accuracy is very useful. So what should we do? When we are scanning, we should identify the ovary, perform a sweep through the ovary in longitudinal and transverse planes, keep the ovary in its longitudinal plane and decide the direction of the sweep to measure the count follicles, measure the largest follicle, and then count the follicles which are lower from that size. And obviously, larger than 10 follicles 10 millimeters should be excluded from the count. And of course, you can see various multivariate models have shown both AFC and AMH is pretty much standard. You can add age, AMC, and AFC. You can add age, AMC, AFC, and FSH. And I think the AFC and AMH is good enough, but age, AMC, and AFC is the one which holds good. So I would say the question of, with ethnicity, is there a difference in the IVF or ICSI injection treatment? And that has been extrapolated to other groups and has not been shown. And you can see here the white population, the Southeast, the African, BRAC, and the Middle Eastern, there is a difference in these two groups, but not with the Southeast Asian. So it's an important study which demonstrated that. I'll skip this slide. Again, similar. So let's, the last few minutes is on what I do as such. So I will consult a patient, and on the same day, I'll be scanning her, and of course, doing a hycosy at the same time, checking her tubes. So when I'm assessing her for ovarian reserve purposes, the FSH, if it is already done before she's come to me, that's the level I follow, very keep it simple. But the AMH I follow for my patients is, if the patient's AMH is less than 3, I say your reserve is very low and you're perimenopausal. So your success rates are like under 1, 2, 3, 4%. If the AMH is between 3 and 17, then I don't take age in the parameter, I just take the level. So 3 to 17, 3 is towards very low and 17 is towards average. And I take the average level as 17 to 35. And obviously above 35, I take it as good reserve of polycystic ovary. So that's your blood hormone assessment before I've scanned them. If I'm doing a scan, these are the 3 groups of women I'll be seeing. So the uterus there, and you got the endometrium is thin. She's a lady who's just finished her period, and she's come to see me for a follicle assessment. And this woman is somebody with low reserve. She's got 3 follicles. You can see this one is almost like 10 millimeters. So she's got 2 or 3 follicles, and this is a very low or low reserve category. This is the average reserve. You've got about 8 or 9 follicles, and this woman is polycystic. So these are my 3 groups of women that I'll be seeing in my clinic. And if this woman comes back a week later, you can see all 3 of them will be having a triple layer, a dominant follicle who's about to ovulate. And then they come back a week later, that same dominant follicle is gone, it's collapsed. There's a nice Doppler flow around it, and a lovely luteal endometrium for implantation. So that's my assessment for the cycle assessment. And I do an assessment for endometriosis, fibroids, anatomy, uterine malformations at the same times. And then finally, I do the age, reproductive age group assessment. So for that, this is what I follow: the ultrasound scan, antral follicle count, I do it for each ovary. So if the follicle count is 1 to 2, I call them very low. So below 3 AMH and 1 to 2 follicles are correlating with each other. If the follicle count is between 3 and 5, I call them low reserve. 6 to 11, I call them average, but when I say when it's 6, it's more closer to 3 to 5. And if it's 12 or more, it's polycystic. So that's my reserve assessment. And the management, I've already said. If somebody's got low reserve, I'll do early IVF. And I'll be assessing for high number of euploid embryos or high-grade embryos, which may lead to successful outcome. So you may do PGTA in these patients to assess that the embryos are euploid and transfer them, or you just do normal embryos being high-grade embryos being transferred if they don't want PGTA. The other thing I do about a patient with low reserve is I do 3 cycles and then I do them back to back. And the first 2 cycles, I freeze the embryos. And the 3rd cycle, I do a fresh transfer. And the reason being that, as in Sankara's study, the more good quality eggs and embryos you've got, the number of live birth rate goes up. So if I can get more embryos to start with in the bank, my chance of giving the woman a baby goes up. So I will freeze the first cycle embryos, freeze the second one, and then the 3rd one I'll be putting back fresh. There are situations where we find that the reserve is extremely low, and we may consider dual stimulation. That means you stimulate and collect the eggs, and then after 4 or 5 days, we start stimulation again. What I've realized is that if you want to do dual stimulation, your trigger should be with GnRH analogs, and that way the corpus luteum regress quickly, and then when you stimulate, then the follicles which are smaller will grow faster. So keep that in mind. So the bottom line is low reserve, lower chance of getting pregnancy. They can still get pregnancy, still have live birth rates. They need to have more collection of oocytes and embryos, and that may achieve the goal of having a baby. There is a higher miscarriage rate, higher need, a chance of abnormalities, and the options of egg donation should be always discussed. I'll stop here and I'll be happy to take questions if anybody wants.
Thank you so much, Dr. Kamal. That was a very enlightening talk. I just wanted to ask you one thing, that what do you consider as the role of DHEA and CoQ10 in enhancing the ovarian reserve?
So these are subtle medications which have, the evidence is questionable. So DHEA, again, in our practice, patients come to us asking for taking DHEA. There are a few centers internationally that use DHEA routinely. And there's one study published from India itself, which is a randomized study, which is a small study, I think from middle of India, either Nagpur or somewhere, I can't remember exactly, which showed that there was evidence of benefit. But overall, there are question marks about the role of DHEA. So for students, the DHEA is supposed to be the feed for an egg. There is no egg that is poor quality. That's the theory. Every egg is good. Only thing, the feed is not good. So if you give DHEA, the egg should be good. Theory, fantastic. In practice, I would say I don't use DHEA.
And CoQ10?
It delays the treatment for 3 months, because you have to give it for 3 months before you treat. By the time the reserve may drop. Some patients want to take it. I say, tell them to take 25 milligrams 3 times a day. I prepare a leaflet showing the androgen effects of hair loss and acne and other things. So they need to be aware of that. So CoQ10, again, CoQ10 is harmless in its own way. The studies have shown that there are 30% better oocyte quality with CoQ10. Now, these are soft studies. They're not very strong studies. And therefore, if somebody wants to take it, I don't, but they're quite expensive here. I don't know about the cost there, but it's quite expensive here. So we have to tell the patients, and some patients say, I will take it, and some patients say they don't want to take it.
Okay. What is the practice of ovarian rejuvenation, PRP in UK?
So nobody does ovarian rejuvenation in the UK. It is not being brought into clinical practice. People have discussed it, talked about it, but it's not being practiced here.
So what if some patient asks you for some medication Can you try to improve the ovarian reserve? Then would you just say there's nothing, or would you give her DHEA, CoQ10, maybe micronutrients? And I mean, what is your take on that? Any role of diet?
Yeah, so we have a huge investment into these aspects. So I have a trained nurse who has read about all the evidence, and she'll go through with the patient. So there is a book for those who want to read called Egg Comes First.
Okay.
And that has analyzed, is a pediatrician who underwent IVF. And she wrote the book, and she read all the publications of all the nutrients, including DHEA and CoQ10 and all that. So we use that theme from there and tell the patient, because patients are just like anywhere in the world. They're demanding, I want CoQ10, I want this, I want this. I said, you can take it, but these are the points that you need to understand. So it is there in my practice, where some patients end up taking CoQ10 and DHEA, but it's the informed decision process.
Yeah. Then you give them guarded reviews about it.
Exactly. We give them the exact publications and the information. We've created an information leaflet for almost everything.
Okay.
So we provide them that information so that they have read it and they've understood it.
Yeah.
With permission of the chair, can I ask a question?
Yes, Pragya.
Yeah, of
Pragya
course.
Mishra, yeah. It was a fantastic presentation as usual by Dr. Oja. There was one of your last few slides where I just want to get some clarification, which was regarding the AMH, where you have shown that less than 3 is poor ovarian reserve, 3 to 17 you still consider as low, and then above 17. So I was wondering, are you talking about in nanograms per
No.
mils or what?
No.
No, that's not nanogram.
That's
No.
picogram. That's the UK measurements are different from the India. So
Yeah,
that's why.
that's
it's
not
confusing.
nanograms, Pragya.
Sorry.
Oh, because I got a bit confused because,
Yes,
here, like if it's generally above 3, you tell them it's indicated of PCOD.
Yeah.
So here, in fact,
Sorry.
I
This
wanted
is the UK. Everything is different,
Actually, Dr. Kamal told in the beginning only that we
Oh.
are following nanograms. So that is different from what the figures he's given.
Yeah.
Yes.
No, so what's the unit that you're using there?
Picograms, PG.
Okay.
So they are different. They're different. Yeah.
Oh,
Your levels, what you are thinking is correct.
because
Mine is for UK population.
Above 3, you tell them 3 nanograms per mils. We tell them it's like PCOD. So perhaps I missed the beginning part. So
Yeah. In the beginning only he clarified.
Right.
I mean, I wanted to take a picture of that slide, but I couldn't.
I'm happy to share my slides. That's no problem.
Dr. Kamal, it was a fantastic presentation, and thank you so much for sparing your time from your busy OT schedule and enlightening our delegates on poor ovarian reserve.
Yeah, and now you can really go and enjoy the weather also.
No, he has to finish up his OT list.
But he was wanting to enjoy the weather.
Well, the sunset here is at 9:30, so 9 o'clock.
Yeah.
Almost. So we do get sun in the evening also. So long days.
Yeah.
Thank you so much for inviting me, and really great to meet all of y'all. And and
Hi, Dr. Kamal. I did not say hello to you. Hi, I haven't
Hi,
listened to you.
Narendra. Hi, Narendra.
It's been a long time since we met.
Hi, Dr. Kamal.
Hi there. Hi. Yes, so nice meeting you all also.
Congratulations, Lakshmi. Fantastic ICOG chairperson.
Fantastic
It's
lecture.
really, her academics are going at its peak.
Thank you. So now we can say bye to Kamal so that he can start his OT, and we will go ahead with our inauguration program. Thank you so much once again, Dr. Kamal.
Bye, Dr. Kamal.
The same session in AICOG with him. We were 3 of us in 1 hour.
Yes, I saw that. Yeah. Okay, take care, guys. Have a nice time, and we'll meet soon.
Bye. So Supriya, we will finish our inauguration. Yeah.
Yeah.
Chitragala, are you with us? Yeah.
Hello, Dr. Arup Kumar. Congratulations.
Thank you.
So we now, yeah, Dr. Arup Kumar Majhi is our president of National ISOPA, and to introduce him formally, he is Professor Santiniketan Medical College, Bolapur, West Bengal, and you can see he is a hardcore academician. And I must say, sir, you are very approachable, humble, and you encourage your juniors a lot. He was president of Kolkata chapter of ISOPA 2018-20. He was scientific committee co-chairperson, AICOG. Was one of the best
Hello?
AICOG which we all experienced. Please mute yourself. Yeah. And as you all can see, he has got more than 100 publications. He is editor of Indian Journal of Perinatology and Reproductive Biology. And he was past national corresponding editor of our Foxy journal, that is Jogi. So welcome you, sir. And can we introduce the guest of honors as well, Chitrakala? So today we are really privileged to have Dr. Narendra Malhotra, sir. Sir, welcome, Sirji. He is, you all know, he has got so many posts. I am not going to read his slides, but I had the opportunity to work with him when he was Foxy president, and I was chairperson HIV/AIDS committee of Foxy. And he again gave me free hand, and under his able leadership, I could start Asia's first HIV PEP helpline. We had organized first World Congress on HIV in women under his visionary leadership. And as you all can see, he has so many posts in so many organizations, and he is a teacher par excellence, sir. And all over the world, I know you have got students and you are conducting courses on ultrasound and Doppler. He is again a great academician. If you just have a look at his CV, over 125 papers and 300 chapters, and he has presented 500 papers, sir, mind-boggling. Over 1,000 guest lectures in India and abroad. He has delivered 56 orations, and he has published so many papers. Friends, his list of achievements and awards are too many. And we are so happy and privileged to have you as our guest of honor, sir. Welcome you on this platform of National ISOPA.
Thank you. Thank you.
And I will just introduce Dr. Pragya also, and then we can have your pearls of wisdom. Pragya, dear friend, always there to guide for all the activities of my committee. She is currently the Secretary General of our National ISOPA, and she is consultant infertility specialist at New Life Test Tube Baby Center, and chairperson. She was chairperson of Genetic and Fetal Medicine Committee, Foxy. She was founder secretary of Bihar chapter of ISAR, and again you can see so many accolades to her CV. She is examiner for MRCOG clinical examination, and she has been awarded Healthcare Professional of the Year 2018 Bihar Gynecologist Award. And she has contributed chapters to so many books. She has published papers, and she was organizing secretary of 24th Boxcon. So, Pradnya, welcome you as guest of honor for this webinar. So I think we should start with your pearls of wisdom, then Dr. Narendra Malhotra, and then our chief guest, Dr. Arup Kumar Majhi.
Madam, sorry to interrupt. Just for lighting of the lamp.
Yeah, I forgot. Yeah, we should take the blessings. Yeah. Chitrakala? So Pragya, we start with you as pearls of wisdom. Yeah. Your guest of honor, yes.
Well, good evening, and at the outset, I would thank you first of all for giving me this honor to become the guest of honor for today's occasion. And for those of you who don't know, this Fertility Enhancement Committee of ISOPAB was launched recently, beginning of this year 2023, with under the whose chairperson is Dr. Lakshmi Srikhande, and it is one of the 5 committees of ISOPAB. So the chief guest of today's occasion, Dr. Arup Majhi, guest of honor, Dr. Narendra Malhotra. Then we have chairpersons, Dr. Ranjana Khanna and Dr. Rita Sinha. And we have Dr. Archana Sinha and Archana Verma and Dr. Archana Kumari, and the 2 erudite speakers of today. One of them we already heard, Dr. Kamal Ojha, who is a friend to many of us because he has been visiting India for so long for AICOGs. And our second speaker, Dr. Sunita Tandulwadkar, as well. Everyone is so eager to, she's one of the presidential candidates also for AIC, for FOXI. So it is nice, to see how Dr. Lakshmi Srikhande has just selected the cream people. The 2 speakers. Really admire her brains, to select Dr. Kamal Ojha and Dr. Sunita Tandulwadkar. And both the topics, especially, poor ovarian reserve, just like, we see that male fertility is declining. These days, even female fertility is on the decline. So our clinics are, just like crowded by women, who are actually having poor ovarian reserve. So it was so nice to get so much of clarity from Dr. Kamal Ojha and on the latest, what they are practicing, and about AFC, AMH, whatever he said was actually, it must have been very fruitful to all the delegates. And I'm sure that, Dr. Sunita Tandulwadkar's topic on optimizing IUI outcome is also going to be great. And it's one topic which most of the gynecologists, they really, because, maximum gynecologists are doing IUI. It's a very common thing. So I'm sure she's going to throw a lot of light, on the latest in IUI. So I really congratulate Dr. Lakshmi Srikhande for organizing this second program under the platform of Fertility Enhancement Committee of ISOPAB, and also thanking her for not forgetting me. She remembered me last time and this time as well. So thank you so much, and I'm sure this program is going to be a great hit, and in future also it's going to be a real academic bonanza for all of us, your next seed to bloom and further on. So wish you all the best for that. And also to Dr. Supriya Jaiswal, who is the co-convener for this program at the MOC. So wish you also all the best. So thank you so much, for inviting me as guest of honor.
Yeah, this time we have involved 4 chapters, and we have decided that by rotation we will have 4 city chapters to involve in our committee webinars, and we forgot to mention that line. But you can see that 4 representatives of 4 chapters are here: Prayagraj, Patna, Ranchi, and West UP chapter. So we just forgot to write that in association with these 4 chapters, but we have invited their president, secretaries as the chairpersons for this webinar. And from future webinars also, we will take by rotation 4 city chapters with us.
That would be a good idea, because then, you can focus and also select speakers from these city chapters. And I also wish Dr. Sunita Tandulwadkar all the best, in her endeavor as FOXI president.
Thank you, Pragya. Thank you. Now, Narendra sir. Sirji.
Very good evening to all of you. Namaskar, everyone. It's indeed a pleasure to be here associated with all these webinars. Today is a busy day. There is CEPHOG webinar just after this, and there is a physical meeting in Agra on contraception just after that. So I'm going to be there everywhere. So it's see, ISOPAB has done great in the last few years. This organization is quite old, and I've been associated with it right from very beginning. And the best part is it encompasses human reproduction, and that touching those aspects, including perinatology and including these problems like POI, is very, very important. And POI, as it is now going to be known, or new terminology, is not uncommon. We are all surprised at the girls coming at 27 to 30 with very low AMH, irregular periods, prolonged, frequent periods, and not getting married and not planning children. It's a major problem. It's a decline in fertility. It's going to be very, very dangerous later on. Maybe God's way to control population, but we don't want it controlled like this, because it is going to pose a challenge to the IVF specialist and to the infertility specialist on how to get them pregnant. So we just heard Kamal was a very good friend. I know him since 1996, when we were first at Chicago Transvaginal, the first World Congress on Transvaginal Ultrasound. And what fun we had there with him. And in the start at Chicago, and when we had more jokes about the TVS probe than the scientific thing. So that's besides the point. So supplements, as Dr. Kamal said, yes, they work, they don't work. There is evidence, there's no evidence, but it is worth giving to them, because you have to give something to this patient to keep them psychologically pacified. What we are now doing is, when these people come, is pooling of oocytes or embryos if they are married. So, and if they don't, fertility preservation, oocyte preservation, embryo preservation. And what Sunita has done is stem cell injection into ovary, and produced the world's first baby born out of stem cell injected into. So congratulations, Dr. Sunita Tendulwar, for showing us the way. We have also now started the same in Agra, and we have now 15 or 20 PRP injected in the ovary. They are ovulating, not yet got a pregnancy, though we are still pooling the eggs. But what I have done different here is, instead of doing laparoscopically, I have attempted transvaginal route. Transvaginal route to inject PRP in the ovary is very difficult. First, you're not using the oocyte pickup needle. So you're not using 17 gauge, you're using 22 gauge. Now, to put a 22 gauge needle through the fornix into a small ovary with a thick cortex is very difficult. And I thank ISAR for publishing my video on the technique. If you've not got it, the ISAR Video Express has the video, which has just been released 4 days back, on how we do it. So yes, that can be attempted, which we are starting. Let's see, let's hope the results, what they come. Then, of course, finally, we'll land up making artificial gametes, which is not very far. And artificial gametes means we take a skin cell from your skin, convert it into sperm or oocyte, and from your skin, one cell convert into oocyte, the other cell into a sperm. So 100% baby is yours. You don't even need a wife, or you don't even need a husband. We, of course, need a woman to carry that baby. But that also in the next 20 years is going to go, because artificial wombs has come. And by 2070, if any one of us are alive, some 25% of pregnancies are predicted to be in artificial wombs outside the womb. And maybe in an animal's womb. Gau hamari mata hai might come correct.
My God.
So something ancient is coming correct. And that is what it is. So it is, thank you very much for inviting me here. These were some thoughts which came randomly to me. I'm preparing my lecture for Sunita's conference on 28th. So these are the thoughts which came, and I thought I'll share it with you. All the best for this lovely webinar and lovely speakers. Thank you very much.
How would those babies be delivered, out of the cows? That's the thing.
Cesarean section where cows, otherwise cow have a big vagina and they'll come out easily.
Yeah,
No,
exactly.
don't worry. The cow cesarean, no one will take off.
Cesarean section rate will fall to 0.
Fantastic, sir. Some novel thought process and ideas you have shared. Thank you so much. I invite our President, Dr. Arut Kumar Majhi. Sir, your blessings and pearls of wisdom.
Very good evening, everybody. Dr. Respected Dr. Malhotra, our guest of honor, also the past policy president, and he has highlighted all the topics today. Very fortunate to hear. And another guest of honor, Dr. Program Mr. Choudhury, our Secretary General, ISOPAR. And it is a great honor, pleasure, and privilege for me to be present in the second episode of Seed to Bloom series. The first episode I witnessed also, that was also fantastic. 28th March, that is the opening, and that was organized by the Fertility Enhancement Committee of ISOPAR under the chairmanship of none other than the very enthusiastic, the active person, Lakshmi Sikandre, and he has come to the ISOPAR, not only ISOPAR, throughout the India and internationally, they are very active and showing her work. And also, my thanks to Dr. Supriya Jaiswal, the co-convener, who is also very enthusiastic member of the ISOPAR and arranging, organizing everything. ISOPAR, all of you know, is a very old society, formed in 1978. And now has begun, Dr. Malhotra has said, last 2 years it is increasing, and 40 chapters now at present. And very soon we will open another 2 chapters. One is the Uttarakhand and another Bihar, and also one in the Bengal in future. And today there are 2 important topics. The poor ovarian reserve. I have really heard from none other than Dr. Kamal Ojha. He is actually from the Kolkata, Bengal, R.G. Kar Medical College, in which college I from retired after 9 years of professor and HOD in that college in the last year. He is the student of the R.G. Kar College, R.G. Kar Medical College. And after that, he went from the BHU to the, and also now is a renowned international worker in the field of reproductive medicine. And another topic is the optimizing IUI outcome that will be delivered none other than Dr. Sunita Tendulkar. All of you know her, how she is working on different fields, particularly in the field of reproductive medicine. And Sunita Tendulkar was the first vice president, and she has so many posts in her post, in her career. We all have been said now. Now all the chairpersons are very known and eminent personalities. Dr. Ranjana Khanna, and there are 4 persons, actually 4 chapters. Dr. Lakshmi has said clearly. Ranjana Khanna is the president, Prayagraj chapter. Dr. Rita Sinha is the president, Patna chapter. Dr. Archana Bharma, president, West UP chapter, and Dr. Archana Kumari, secretary, Ranchi chapter. All are very well known to me and well known to all in India. Hope there will be a very good discussion. Already one part I am in between the 2 lecture, 2 presentation. One has been discussed, and another will be very good discussion and enrichment of the knowledge of all the audiences. And I wish great success of this webinar. Again, congratulations to Lakshmi Sikandre and Dr. Supriya Jaiswal. Long live ISOPAR. Thank you all. Thank you.
Thank you so much, sir. So, Supriya, let's introduce to chairperson. Sunita is waiting for her talk. So, we will proceed with the second lecture of this webinar. Chitrakala, please show the slides, CV slides. Yeah.
So to begin with the second session, we have optimizing IUI outcome by Dr. Sunita Tendulkar. To chair the session, we have President West UP chapter ISOPAR, Dr. Archana Verma and Dr. Archana Kumari. But I think Dr. Archana Verma couldn't join. She had some commitment. She might join in between. So over to next slide, please. Dr. Archana Kumari, she is Secretary ISOPAR Ranchi chapter and also founder secretary of IFS Jharkhand Bihar Jharkhand chapter. Then she is organizing secretary of FOXI East Zonal Conference with Yuva 2022 at Ranchi. She had been the organizing secretary of 8th Annual Conference of ROCS 2009, organizing secretary of Midterm Annual Conference ISOPAP 2019. She has great teaching experience of 18 years and has been awarded by MS Signature Award in 2021, Dhira Award in 2022, and Foxy Achievers Award. She had been Best Paper Award at East Zone Yuva Foxy 2007 and 2008. So with these words, I welcome you, Dr. Archana, and over to you to introduce the speaker.
Chitrakala, please show. Yeah.
Just unmute yourself.
Archana, you are here to introduce Sunita.
Yeah, she's there.
Yeah.
You'll have to unmute yourself. We can't hear you.
Oh.
Yeah, now, yes.
I'm audible now?
Yes, yes.
So, good evening, everyone. At the outset, I would like to express my regards to Dr. Arup Kumar Majhi, sir, the President, National ISOPAP and Chief Guest for today's function. My regards to Dr. Naren Malhotra, sir, Dr. Pragya Mishra, and of course, my extreme thanks, heartfelt thanks to Dr. Lakshmi Khande ma'am, the convener of this excellent Seed to Bloom series, and of course, Dr. Supriya for giving me this opportunity. It is indeed a huge honor to introduce an iconic personality like Dr. Sunita Tendulkar ma'am. Ma'am is a well-known personality, but as a formality, I have to introduce her. She is the head of the Department of OBGYN,
That's
and
okay.
chief of the IVF and Endoscopy Center, Ruby Hall Clinic, Pune.
Archana,
She is the
that's
advisor
okay.
and consultant of DY Patil IVF and Endoscopy Center. And she has so many accolades and achievements to her record. So if
No, Archana
madam,
ji, for academic,
you want me to...
No, Archana ji, please, let's move on.
No, Sunita, just a minute. I know
and
you
we
don't
are
need-
eager to
Sunita,
hear from
just a
you
minute.
about
Sunita,
optimizing IUI outcome.
Sunita,
charger laga.
Sunita, just a minute. I know you don't need any introduction. I am not going to read your slide, but I would like to tell our audience that friend, she is the academician, par excellence, orator, par excellence. We all have witnessed her surgeries during live histoscopy and laparoscopy workshop. But above all, she is a great human being and a trusted friend who is always there, who will go beyond her call of duty to come to the rescue of her friends, colleagues, and everyone. And I know Sunita since more than 30 years. And friends, she has headed so many organizations. So her leadership capacity is also, I mean, she has proved it beyond doubt that she is a great leader. So I just wanted these few qualities. I'm saying few, Sunita, I know you have got many qualities, but these are few qualities as a human being apart from your academic achievements. So I hand over to Sunita for her talk on optimizing IUI outcome.
Thank you, everybody. I have no words to express the love by Lakshmi. ISOPAP, Dr. Arup Kumar Majhi, we were there in Meerut to witness your getting installed as a presidency, and it was a proud moment for each and every Bengal OBGYN society, the way they came for you. I can see the amount of respect you gathered over years with them. Pragya, ISOPAP secretary, and my chairperson, Dr. Archana Kumari. Thank you for your kind words. And now Lakshmi, the chairperson of Foxy ICOG, a fantastic work, more than a work, our friendship. It speaks volume. And Supriya, you have chosen the right person to be a co-convener with you. Very sincere, hardworking chairperson of Foxy. Ranjana, my very dear friend, we were the co-vice president. So it seems so beautiful now. You feel like you are at home, though you are at home in your own place. Looking forward to see you all. And thank you, Lakshmi, for giving me the topic of my absolute choice. It's my interest in it. Let's speak on optimizing IUI results. How do we work on? Friends, I always say, don't limit your challenges. Challenge your limit. Each day we must strive for constant, never-ending improvement. We are doing this practice for now more than 30 years. The same type of patient, same, but every patient needs their hope to be fulfilled. And that's why it's important that we perform every day. Can I ask you only one thing, Archana ji? How much time do I have? This topic is so big, so I don't know.
You have
I
20
just-
minutes, madam.
It's a
I think
30
it is
minutes.
20
half an
minutes,
hour.
20 minutes. You can take another
Yeah.
5 minutes, ma'am.
Okay, because I saw 4:30 to 6, 2 talks. I thought half hour inauguration. So anyway, because this topic you can talk for hours together. So after failure of expectant management, the next line of treatment, especially in young patients with short duration of infertility and no severe male infertility or tubal factor, is always IUI, especially in India. Ashwini, awaaz kami karshe. So what are the various levels at which IUI success can be optimized? So I always tell all my fellows, concentrate on not every patient coming here, I will take care for a IUI. You have to select. If you want good results for a IUI, it means your selection criteria has to be very stringent. So selection of your patient, what is your induction protocol? How do you monitor your cycle? When do you time the trigger? What is your timing of insemination? How you do the IUI procedure and what support you give? All these matter when it comes to the IUI success rate. So now let's select the patient. In one word, if I have to say, younger the patient, better the results. First 3 IUI cycles have the best result than subsequent. Patient with the good reservoir will have a better result. Patient with the acceptable semen will have a better results. But if you want to say about indication, which patient shall I select? So these are the 4 indication mainly: the polycystic ovaries, the unexplained endometriosis, or the male infertility. These are the patients which we discussed. Let's see the experience, evidence, and where we stand with it. Now, do ovulation induction differ when the patient, when you are, see, IUI when you do with the natural cycle or the oral ovulation? Do it differ? Of course. In natural cycle, it is very difficult to time IUI. Friends, the life of oocyte is just 12 hours. Suppose you have done today the sonography 4 p.m. and you saw that the follicle is 18 mm, you felt that it is not going to ovulate, and next day patient comes, she's already ovulated. If you ask her history of a pain, she says, in the night I had. Now 4 o'clock, you are not going to do the IUI. So you may land up because husband may not be accompanying. Now on Monday evening, for example, her follicle got ruptured. Tuesday you saw it, you were not expecting. And Wednesday you are going to do, the egg is dead by that time. So to time the ovulation, you need to induce the patient even if she is ovulating, so that you can time her IUI. Now, when I want to do induction, whether oral is better or injectable is better. And when I want to give an injectable, whether it is a gonadotropin, HMG, or the recombinant, which is better? Where do we stand today? That's the most important. No, range zate, I can't close the door. So will it differ in a patient if she is unovulatory and ovulatory? So if it is a PCOS patient or if it is an unexplained infertility, it may be the patients of male subfertility or endometriosis where we expect ovulatory. Does they differ? Yes, it do differ. And I'm going to tell you that also. So what should be first your goal? Monofollicular development. It should be least invasive, simplest, cheapest. you should maximize the rate of singleton pregnancy and minimize the multiple pregnancy and minimize the risk of OHSS. This is all should be your protocol. Patient respond differently to ovarian stimulation. The objective should be optimize your response and outcome and minimize the risk. So when I want to start, before starting the ovarian analysis of the ovarian reserve, do that. So before starting the ovarian stimulation, you should have two important things. Select the correct and define the goal. Is it for IUI? And if it is for IUI, is it anovulatory or ovulatory patient? And how do I select? There are many tests of the doing the ovarian reserve testing. What we do commonly use are only two. One, on a sonography, AFI, and second, the AMH. So we decide with the age of the patient, her AMH and antral follicle count. If she has a stimulation before in a previous cycle, that cycle stimulation response is the best guide you can get on with. Now, usually the question is asked when to start this stimulation. So now I'm not only going to tell you the evidence, which is better in what, but when to start. Now imagine if you are going to have monofollicular growth you want, and the patient is ovulatory. It means you want to sustain the follicle which is becoming dominant follicle. The story will be different. While those anovulatory or where you want to stimulate, your patient is ovulatory, but you want to have 2 or 3 follicle, your day of stimulation starts differently. And I'm going to explain you with this simple diagram. We all know that the corpus gets stimulated, and by day 6, the dominant follicle gets selected. This dominant follicle definitely have more E2 value. It decreases the FSH by negative feedback. That decreasing FSH is sufficient for a dominant follicle to survive because it has many granulosa cells. So its receptors have increased tenfolds. And also it has a selective vascularity. So there is a selective deposition of that FSH. While for the rest of the follicle, decreasing FSH is not sufficient and they become androgenic follicles, and the androgenic follicle undergoes atresia. Now, once they undergo atresia, it becomes irreversible. So usually by day 5, day 6, the dominant follicle become, and day 7, 8 onwards, this atresia. Now, if my aim is to rescue 1, 2 more follicle, obviously I need to start the stimulation before day 6, before they undergo atresia, before they become androgenic, before they go in an irreversible path of coming down. But if my aim is to just improve the follicular phase of the follicle so that the quality and the luteal phase both will increase. The quality of oocyte and the luteal phase. The quality of oocyte because I'm optimizing intrafollicular environment of the dominant follicle. Then obviously my stimulation will start day 6. Now, whether it is oral Ovulogen or whether it is injectable, this simple principle will make you understand. So these are the follicles. One of the follicle I want to rescue. I will give the gonadotropin before the day 5. I will rescue. Now, it is your dose of a gonadotropin which will decide whether you will rescue 1 follicle or you will rescue 2 follicles or you will rescue all the follicles as if it is a IVF where we want to rescue all the follicle. While here, the dose of gonadotropin will be obviously very less so that I rescue maybe 1 or 2 follicle. We all know the evidence has proved that when you have 2 or 3 follicles, the success of your IUI cycle is more than when you have 1 follicle. So if you understood this basic concept very well, when to start your stimulation, where you will be successful in your stimulation protocols. Now, what about the PCOS? What does the Cochrane says? Aromatase inhibitors. If you see the Cochrane from 2017 onward, before always it used to be letrozole is non-inferior. Any new drug comes, first they have to prove that they are not inferior to the another which is existing, that is clomiphene. And then they have to prove that their complication rates are also less or at least at par. Here the complication rate is OHSS or the multiple pregnancy. And we have to see as the science advances, we start proving that it is not only non-inferior, but it is at par or maybe superior. So if you see early Cochrane, it used to say letrozole not inferior. Then it came that letrozole, probably there is no difference in the live birth. I have already explained to you when to add gonadotropin, depending upon what was your aim of stimulation, then which gonadotropin. In a PCOS patient, gonadotropin or a laparoscopic surgery is considered second line. So either you give letrozole or a clomiphene for 3 to 4 cycles. And if the patient is letrozole failure or letrozole resistance, failure means you ovulated but did not conceive, and letrozole resistance means she did not ovulate at all. Then the second line of treatment is laparoscopic ovarian drilling or addition of gonadotropin, and third line of treatment always is the ART. Of course, lifestyle modification remains the primary. Now, Cochrane about the gonadotropins in PCOS patient. Let's talk PCOS separately from those with the unexplained, which are naturally ovulating. So what does the Cochrane evidence says? From 2001 to 2000 to 2015, Cochrane says urinary gonadotropin and recombinant are the same. There is no superiority of recombinant. So what do I do in my routine practice? Of course, HMG is my drug of choice because, as I said, IUI success is going to be low. So you need to be cost effective. So don't use recombinant? No, I do use recombinant. Now, when there are certain patients who cannot come, they want self-administration, or you want to titrate the dose as low as 37.5, then these are recombinant comes with the pre-filled syringes, and it becomes very easy to calculate the dose. So for different comfort, I can pack up the pen and give it to the patient and teach her how to take those 37.5 dose or how to take a 50 IU dose and keep on taking self at home. So she don't have to walk in your cabin every day just for the injection. So these are the patients where I will think about using recombinant. Otherwise, don't think your success is going to be high. Now, about the insulin sensitizers, few lines. When you started in 2017 with the metformin, what the Cochrane, I know Cochrane most of the time doesn't give you answer, says insufficient data. But as far as metformin is concerned, they said improvement in the clinical pregnancy and ovulation rate, but whether when you are giving with the oral ovulogens, friends, I'm talking about metformin with oral ovulogens and not with the gonadotropin. With oral ovulogen, they said the live birth is not increased. Why I'm specifying this? Because the evidence says that when you use with the injectable, the live birth has increased. Now, metformin in 2019, metformin for ovulation induction, they have done a beautiful collection of 41 studies with 4,500 patients, and they studied all combination of metformin with placebo, alone metformin, or with the oral ovulogens, different type with laparoscopic drilling and all. And they said, when you are using with placebo, definitely metformin improves the result. When you are giving metformin with the CC, definitely they are better. Though the live birth we don't know, but ovulation rate is definitely better. Pregnancy rate is better. Whether it will convert to live birth is still inconclusive. And what is important is there is one study which definitely say that it is better to use a metformin along with letrozole than laparoscopic drilling. What about the gonadotrophins and metformin? Even the Cochrane say that metformin, when given in a PCOS patient, along with injectable gonadotrophins for a IUI, it increases the live birth rate. Friends, in my practice, all patients which are especially, I know that they are obese, they have a hyperandrogenism, showing that there is an insulin resistance. I not only start them on metformin, but I continue this metformin throughout the pregnancy. Now there are ample evidences to prove that use of metformin in pregnancy will definitely decrease your incidence of gestational diabetes. Luteal phase clomiphene, do anyone start? There are certain studies which also says that now we know that the cohort can get stimulated even in the luteal phase, and you can stimulate, though I don't have personal experience of clomiphene using in a luteal phase. Now, combination of a letrozole and clomiphene or letrozole alone. Friends, again, let me tell you, I use extended letrozole. Instead of 5 days, I give them 7 days, 10 days letrozole. But I have never used the letrozole and clomiphene combination. But people say that there can be higher ovulation rate. I'm worried about the OHSS. What about the stimulation protocol in unexplained ovulatory patient? Let's start evidence-based. If you want to see the evidence, you will find hundreds of studies with different type. Sometimes they have used only time IC, sometimes they have used expectant management, and sometimes they have compared even the IVF and ICSI. What does they say? That the results are expectant results. Management may be comparable only to oral ovulation with TIC. It means you just give a counseling to the patient, explain them that it may be just the fear, because we all know that the stress itself can affect the HPO axis. But what we do routinely is we stimulate these patients with oral ovulation and sometimes with the gonadotrophin, as we do in PCOS. Here we aim to get 2 or 3 follicles, maybe 1 on this side and 2 on the other side. Whether this is tubo-ovarian relationship, it will work, or the contralateral side, but we like to work. But in unexplained infertility, they have proved that recombinant may be giving better results than HMG. So friends, if it is for a PCOS, actually, if you start thinking in your mind, the PCOS patient have a high LH in early part of a follicular phase. By giving a HMG, we are adding the LH. So you may think logically that it is adding fuel in a fire, but evidence doesn't say that. While in unexplained, evidence says that recombinant is superior. I'm not going to go in detail about the FAST trial, because FAST trial is not accepted in UK itself, where they conferred 3 cycles of oral ovulation and IUI, 3 cycles of gonadotrophins and IUI, and up to 6 cycles of IVF on one arm. And in second arm, they did not give a gonadotrophins with IUI. They felt that if oral ovulation did not work, they directly went for the IVF, thinking that IVF is a superior option. but only 4% uptake of this because IUI is still the better option. Gonadotrophins with IUI in selected patients in a cumulative at 3 cycle can give as good results as IVF. And that's why they have not. And Roy Homburg in 2019, he proved beyond himself that IUI it has its own efficacy. It is more cost effective, and he promoted IUI a lot in UK. We all know that now he shifted to UK. Observational studies which they have done with the UK nationals as against the FAST trial with 3 lakh of IVF cycle with 30,000. And they all said that IUI success in today's world is much closer to IVF than previously reported, and it may be cost effective. So friends, IUI will play its own role. Monitor cycle, sonography, mandatory. When? On day 2 of the cycle, before you start the stimulation. Ensure that ovaries are down-regulated. Never give any medicine on phone that on day 2 you start this medicine, nothing to worry, come directly on day 7, day 8. That's a major mistake you will be doing. Whether the self-monitoring or with sonologist, I will always say self. Because it is not the monitoring of the follicle alone. There are 3 more important things. When we monitor, we will not see only dominant follicle. It may be 16 by 14 mm. It may be 16 by 17 mm. But I will see how many more lagging behind. I will see the vascularity. I will see the follicular phase growing of endometrial lining. I will check the vascularity of endometrial lining. So many things I will be able to study myself when I do my self-sonography. Do I do the hormone? No, neither blood nor urinary. For my routine IUI cycles, I don't do any hormone monitoring except beta HCG, which I tell the patient on day 17, if their UPT is negative, 4 days of stoppage, they did not got the menses, maybe they should go for a beta HCG, that is the urinary pregnancy test. When do I do hormone monitoring then in a IUI cycle? Only in one condition. I see 2-3 beautiful follicles, probably 15-16 mm. I expect at least 100 E2 from each follicle. So 300 E2, but the lining is just the thin 4 millimeter. It means either these are empty follicles, not secreting enough estradiol, poor quality eggs or no eggs, or the pathology is in the uterine cavity. Only when there is an asynchrony in the size of the follicle and the lining, I will do the E2 value. Now, if E2 value comes 250, 300 with these 3 follicles and the lining is poor 3 millimeter, 4 millimeter, I know and I'll sit with the patient that let me finish this cycle. But if I don't get a success, next cycle, I will be doing evaluation of your uterus, intrauterine and laparoscopy. That is laparohysteroscopy I'll be planning for her. Now, if her A2 value has come just like 30, I know that it is not the fault of the lining, it is fault, and probably I may stimulate her with the gonadotrophin, or I may think of taking her for the higher treatment if they are empty follicles. When to give a trigger? Very important. If you give early, when the oocyte was not mature, or if you give late, when the oocyte was post-mature, you will not get a success. So the timing of a trigger is very important than what you give for a trigger, whether LH or SCG. Naturally, LH, when you are expecting 2-3 follicles, you don't want SCG, you don't want OHSS. We all know the culprit of OHSS is SCG. As long as you don't give a SCG, they will not be having a OHSS. So when do I give? I give between 19 to 20 mm, not at 18. Usually my IUI cycles are monitored by my fellows and I give them 1 mm margin of error. So if it is 17 mm and they are quoting me 18 mm, I know that I may go wrong. So if you give a margin of 19 to 20, 1 minus 1 plus, that's acceptable. When do you do the IUI? Timing of IUI, whether I'm supposed to do at 24 hours or at 36 hours. Friends, the evidence says only 36 hours. There are several studies which prove again and again, double IUI, not acceptable, only single IUI at 36 hours. Do I follow in my practice? Let me tell you, sometimes we don't. Now, do I do this completely in my practice? Only if I had more than 3 follicles and I have given antagonist to prevent the premature LS surge, which itself will be a different subject to discuss some other time. When I know that the ovulation will happen completely at 36 hours because I had given an antagonist, I have stopped the endogenous LS surge, I will give at 36 hours. Otherwise, in my practice, I give monitoring between 4 p.m. to 6 p.m. Now imagine the patient has already endogenous LS surge has started because I don't do urinary LH kits and all. And if I give her a SCG trigger, so I add on to her existing peak, which is happening, then I may have an ovulation early. If I'm giving at 4 p.m. in the afternoon, today is what, Wednesday? Then my IUI at 36 hours becomes 4 a.m. on Friday morning. I'm not going to get up at 4 a.m. My IVF work is going on in the morning hours. So what I do is, I know patient can have an endogenous LH. So today, 4 p.m., if I give, to next day, I call the patient at 1:32 p.m. Not condom, but using a disposable sheath, we do the sonography. 60 to 70% of the time, we see a beautiful follicular fluid in the pouch of a Douglas, and we know that the follicle has ruptured. We do the IUI immediately. If it has not ruptured, then I call the patient, especially if it is for a male subfertility, I call the patient now, next day morning, not at 2 p.m., but at 8:30 a.m. So somewhere in the night or early morning, her follicle is going to rupture. I want to time the IUI as close to the ovulation as possible. So friends, I want all of you to study the endocrinology, to study how the endogenous LH happens, LS surge happens, to find out what time you give your trigger, and then you decide. Though the evidence is very clear that it is 36 hours, that is where you are supposed to plan your IUI. Semen parameters, what you take in your lab is equally important. Ideal semen parameters, if you see many studies, there are so many variables. They have not come out in a single study. This is a beautiful paper, systemic meta-analysis. 983 papers, only 55 met with the criteria. And they say that cutoff value for an inseminating motile count, it means post-wash count, should be between 1 million to 5 million with more than 4% morphology. While in a native sample, unwashed, the cutoff should be 5 to 10 million with 2% motility. Friends, don't keep on playing with IUI. I know many guys have given pregnancy one count with 20% motility. I think they are doing a mistake of the count. DNA fragmentation, do I do it routinely? No. Catheter, which catheter I should use? More expensive, more.
Her network connection is gone now.
Yeah, madam. She might join again.
No, she will log in again.
Yeah.
Meantime, if there are any questions in the chat box, dear delegates, you can post your questions related to Dr. Sunita's talk. She is joining. Yeah.
Lakshmi, you have joined from two places, your mobile and that.
Yeah. But once you mute everything on the other device, it does not interfere.
Okay.
Yeah, I can see one question till she logs in. I can answer. If you are doing IUI, you are stimulating by gonadotropins. So when not to give trigger, when you see 3 or more mature follicles, you should not give trigger. And on case paper, you should write that cycle is cancelled and abstinence is advised. Friends, for that matter, even letrozole has given a sextuplate. You all can go on Google and type, that is a real case where that lady conceived sextuplates only on letrozole stimulation. The treating doctor did told her to practice abstinence, but it is the habit of the patient. She did not, and she landed up with having 6 babies. So whether you are giving clomiphene, letrozole, but of course more cautious should be when you are giving gonadotropin. So 3 or more follicles is the cutoff. If you see too many follicles at the time of trigger, now you can counsel your patient to get the cycle converted into IVF. But friends, that is not that easy because patient is not mentally prepared. In India, our patients are paying from their pocket for IVF. So the cost burden at that last moment for them, it becomes too much. But yes, there is no harm because to be medico-legally safe, give them all the options. That because there are more than 3 follicles, these are your options: cancel the cycle, abstinence, or we can convert your cycle into IVF. Give pros and cons of each and every method and let the couple decide what they want. So this is the condition where you can. Then many places they ask if there are more than 3 follicles, instead of SCG, can we give agonist trigger? No, in IUI, we never give agonist trigger because our concern is not only OHSS, our concern is multiple pregnancies as well. Because in IVF, if there are more follicles, you have the option of embryo freezing. You can have the option of not transferring embryos in that cycle, but in IUI, you don't have. So in IUI, point blanket rule is to cancel the cycle. Don't give agonist. Antagonist, she has already said, when you want to avoid the weekend cycles or as per your convenience, you just add on antagonist to your IUI cycle. So I hope I am clear as far as the role of agonist and antagonist is concerned in the IUI cycle.
Dr. Supriya, are you able to contact?
Yes, I
I
called
told
her.
her she is logging in.
Eh?
Yeah.
She
Trying.
was unable, and Chitrakala is helping her to join.
Yeah. In IUI, again, we are not giving dual trigger. They are all meant for IVF cycles.
Yeah. New guideline.
Yeah.
I want to, in the
Yes,
meantime, I want to inform you one thing. And actually, I was in the very younger days. When I was a house surgeon, I was in the clinic of the Professor B.N. Chakraborty. And B.N. Chakraborty and Dr. Sudarshan Gosdikar, and we are the 4 people, started the intrauterine insemination. And at that time, it was known as the intrauterine insemination. And it is in 1984, just after the demise of the Dr. Subhas Mukherjee. I was in that team. And there is photograph also. And Dr. Evan Parikh visited that place. And we used to do intrauterine insemination at that time. The name was the insemination after was spermatogenese. That was also presented in the Helsinki conference. Professor B.N. Chakraborty and Sudarshan Ghose sir presented that paper also. That is the first IVF was done in 1986 in here. So it's very interesting. I have a story I will tell in the we get the time, and the story of the beginning of the days of the reproductive medicine. And at that time there was no IVF center other than the Indira Hinduja and Sadhana Desai at that time. After that, the formation of the ISAR formation in the 90s, after 90, and Dr. Memen Pari visited that place also and used to learn, and also from the Professor B.N. Chakraborty, I was there, and there is a good photographer also. I will show, not today, and if I get time, I will show what is the history of that. When I used IUI, lot of IUI in my younger days. So my question is actually here, who are doing IUI, Dr. Lakshmi, Dr. Pragya, and who are doing so many.
Sunita has joined now.
Percentage now, percentage, success. What is the success actually?
Success.
I-
Dr. Lakshmi?
Gonadotropin, if I'm using a gonadotropin IUI, my success rate will be 25 to 35% with the 3
25%.
cycles.
Sir,
With the
So
three
IUI
cycles.
success is not so much.
no,
But
no,
what is the minimum you have shown your slide in the sperm count? But what should be the minimum sperm count you go for the IUI?
Sir, 1 million count, I directly take them for ICSI. I never play with 1 million count.
1 million? No.
1 million count, I will never play, sir. Minimum 10 million count with the morphology.
That is the standard, I know.
Yes.
What do you do actually? Below 5 million type of pregnancy is not possible, I think. Not possible.
Sir, ICSI results are so beautiful.
So I will tell the story of the very beginning of the IUIs in India. Professor B.N. Chakraborty, I have worked with him, and he is just devised 1 year back. And there is also very good photograph also, the old photograph. I will show one day. I used to work with B.N. Chakraborty, Dr. Sudarshan Ghose, Dr. Siddhartha Chatterjee, and now Dr. Bani Mitto is working. We are in the same team. But I will go into the health service and all the jack of all, everything. I do the malignant surgery, but reproductive medicine is in my heart. That is why from the very beginning, I learning and hearing all the poor women disorder and optimizing IUI. Very, very interesting topic. And so will you again share slide, Dr. Sunita?
Yeah, it was almost over. I will start sharing, no problem.
Hmm.
So we were coming to the type of a catheter I was talking about. You don't need expensive catheters. You need the catheter which are soft, pliable. More than the type of a catheter, what is important is your technique, the procedure, how you do it. Now, the technique should be non-traumatic. Don't induce the bleeding. The blood will change the pH of the entire atmosphere. So, and try to see that you don't have to hold the cervix. So, frankly speaking, what we do in our places is, so when we check the patient with the before the IUI for the rupture of the follicle with the disposable sheath, my resident fellows, they also have to check how is the uterus. If it is acutely anteverted, they don't empty the bladder. They make the bladder half full so that the procedure goes easily. If the uterus is retroverted, then they ensure that the bladder is empty. That's one very important thing they should do. Now, do you think ultrasound guided will improve the results? Actually, yes, but practically not possible because you need one more expertise to show you with the sonography. In international journals, anywhere, you will find that they say it increases the cost of the patient for an IUI and you need one expert personality. Now, if I'm very sure, for example, Lakshmi Srikhande, if she's checking this follicular fluid rupture or not, she's not charging the sonography charges. It comes free to our patients. Now, what happens is my fellows, they don't get too much of an embryo transfer. So what they do is they do sonography control IUI. They take our embryo transfer catheters, they autoclave them, and they ETO catheters, they put the external catheter, they load on an inner catheter, and they do practice as if they are doing an embryo transfer. So one fellow shows and the other fellow does it. But is that evidence needs it? No. Do you do single and double? I explained already. The evidence tells us that single IUI is only important. Ultrasound guidance, the cost increases, so conventional method may be recommended. Single and double, it is always single when it comes to the evidence. Luteal phase support, to whom, what drug, and how long. The luteal phase support, friends, whenever you are using gonadotrophins, you should be giving a luteal phase support. When you are used only oral Ovulogen and you are giving a SCG as a trigger, you don't need a luteal phase support. The SCG will work for 7 days. Corpus luteum will take care further, and then the placenta. So ideally, only when you use a gonadotrophin, you use a luteal phase support. Otherwise, with oral Ovulogen, you don't need it. Drug of choice nowadays, we all know that oral drug, we shifted all tablet dydrogesterone, 10 milligram twice a day, I give as a dose. How long? If I have started, I don't stop it till 7 weeks. When I see the good decidual reaction and corpus luteum, I stop it in a IUI cycles. Any other issues? Cervical mucus plug removal prior to IUI? No, I don't do. Do I give a rest after IUI? Yes. 5 minutes, let the patient lie on that bed. Actually, the evidence also has shown that 10 minutes of a rest, I will show you the publication, 10 minutes after the rest is improving the IUI result. How many cycles? If you are so closely monitoring your stimulation protocol, you are doing a day 2 scan, you are giving the doses even of the gonadotrophins very carefully, and you are optimizing when to give a trigger and how to do the procedure and the semen parameter. If no success in 3 cycles of IUI, when patient have not done IUI before anywhere else, I will not go on a 4th cycle at all. If the patient has done in some other centers, but I'm not comfortable, I may think of doing only 2 cycles. And after 2 cycles, I will either go for an evaluation, because in IUI, I know I concentrate only on the gametes, egg release and the sperm release. I'm not able to concentrate on whether the union of the 2 sperms are happening and whether the implantation is happening. So if 2 cycles of IUI with the gonadotrophin, no results, when patient had IUI somewhere else before coming to me, I will directly go either for an evaluation or for an IVF, depending upon her age, her AMH, her duration of marriage, and her semen parameters. These are the conditions. Thank you so much. And I stop sharing and we can have a discussion.
Excellent, excellent, Sunita.
Fantastic presentation, Dr. Sunita. Fantastic. And many things we have learned from you. Many things and your work.
Archana Kumari ko unmute.
Dr. Archana, you're mute. And do it unmute.
Unmute yourself. Nobody can hear you, Archana.
You have clarified
Unmute yourself,
question,
Dr. Archana.
Sunita, because most of the times we are asked only these, what type of catheter, cervical plug, whether we should do it under ultrasound guidance. So you have already answered all the questions, and the role of bladder. How does
Yeah, that was very nice. Very, very, very well put,
Yes,
Sunita.
You
Got
know,
am I audible now? Yes, thank
in-
you, Sunita ma'am. That was absolutely flawless talk. You are an excellent teacher. The way you teach every nuances and the little things, what Lakshmi ma'am and Rangana Khanna ma'am was telling, even when to use full bladder, when to go without filling the bladder, and with the help of the diagram, you explained when to give the trigger, how to recruit the follicles. I mean, it was mesmerizing. I think the audience must have learned a lot And we all
One
have
more
also
thing I
enjoyed.
always tell my fellow is they have to first, when they put the vaginal probe in, they have to see the uterus. And depending upon the lining, they have to judge what is the size of the follicle they are expecting. It's a mandatory for them to do that. They can put the color Doppler and see how the flow is going. It's so many things. Just by doing your own sonographies, you can, learn about the patient and her follicle. I always say, when you are doing IUI, behave as if you are follicle itself. What you need more? Are you mature enough to come out? All that you have to feel that you are the one. I need more food, or I don't need more food. All this is important.
And Sunita, one more thing, I know evidence tells you that luteal phase support is not needed for oral ovulations, but to be very honest, we all are giving.
We all are giving. We all are giving.
Your next door.
I'll tell you why we are giving, you know what? Because in India, the patient pays from her pocket. And we are so compelled to give results in very first 1, 2, 3 cycles.
Yeah.
And that's where we feel that if subtle luteal phase deficiency, probably the cause, either she will have a biochemical pregnancy or no pregnancy. And with the fear of that, we give. If we would have been in a university setup where everything is sponsored for the patient, I think we would have done more evidence-based.
Yes,
No,
sir.
but I think also there's that immunological advantage by giving dihydrogesterone. So
That's a totally different ball game.
yeah, so that is
altogether.
why also we like to give, because it adds to the support also, and otherwise also it.
I would like to agree that there should not be any mix and match of progesterones. Give only one type of progesterone.
Only
what does your say on
dihydrogesterone.
that? Because we are giving each and every, we are giving gel also, injection also, oral also.
You know
So
what
you must say-
happens? I'll tell you why, Lakshmi. I'll tell you. Because in IVF cycles, we do sometimes give that, especially when we were not giving oral dihydrogesterone. Till 5 years ago, I was not giving oral progesterone, dihydrogesterone as a luteal phase support alone for a IVF cycle. Only after the Lotus trial, which has proven non-inferior, we all know that Lotus trial has all Abbott executive board members. So how much one should believe that Lotus trial also, because there is always going to be a bias.
Yes.
But what happens, we are not sure about the quality of a drug. In
Yes.
India, what I'm going to get,
Yes.
the sustained gel, or the gel, see the simple lipstick, Revlon lipstick in India, your shade, and Revlon lipstick in US, it's totally different. The numbers are different. It's cosmetic products. What you get in India and what you get in abroad are different. So we are not quality sure about our products of gel. And in IVF, again, our success is matter, especially when we are doing a frozen embryo transfer, when they don't have a corpus luteum, when it is completely outside progesterone. That's where we compel to give injectable and vaginal. But probably in IUI, I don't bother so much because I know there is a corpus luteum.
Yes.
Yeah.
So can't see any more questions. Yes. So Sunita, thank you so much for sparing your
Dr. Lakshmi,
time and
last
enlightening-
slide I can see.
Yes,
I
sir.
can show you one slide.
Yes, sir. Please,
With
sir.
permission. Eh?
Yes, sir. Please, sir. You are the
ET catheter, Lakshmi,
Just I'm
ET
sharing one
catheter, do
slide.
the ETO. Do the ETO and used.
Yes, yes, but provided you are having your own IVF center, Sunita. If
Yeah.
You see this
You know
slide.
what? All my friends, I tell them, take the ETO catheters from us. We'll give you 10 ETO.
yeah, because I am doing,
Okay.
because I have got a lot of, ET catheters available after doing ETO.
You
But
see-
standalone IUI clinics, they don't have that luxury.
Yeah, I agree with you.
But
Sir,
can you
ये
identify
photo
the
थोड़ा enlarge
persons?
करो ना. सर ये
Sunita.
फोटो जरा enlarge करो ना सर, स्लाइड शो में डालो.
सर फुल स्क्रीन करिए, फुल स्क्रीन.
Dr.
फुल
Lakshmi,
स्क्रीन करो, हम पहचानेंगे who
just
is
you
Dr.
identify the person, Dr. Lakshmi.
सर फुल स्क्रीन
Dr.
करिए.
Sunita, just identify the persons. The famous
Dr.
person.
Arup, I will show you where you are. Just screen bigger करो.
फुल स्क्रीन करो, फुल स्क्रीन सर.
Oh, full screen. Okay.
स्लाइड शो में डालो.
फुल स्क्रीन करो, देखते हैं अभी आप टेस्ट ले रहे हो ना तो.
Very old photograph of 1985. Identify the famous persons.
I will just,
Who is he? Who is he actually?
you know what, sitting left, right, from the side, the so-called, whether the first IVF baby with him or not, the controversy, the sitting with the white tie, with the black and white tie. Wo.
This is actually Dr. Maymin Parikh. This is Dr. B.N. Chakraborty. It's 1985.
Sir, बड़ा तो करते नहीं हो आप.
And this is Dr. Bhojdosidar and all team of Kolkata. This is my myself little. Dr.
कौन से
Arup.
सर एरो से बताओ ना.
एरो
This
से
is
बताओ सर, एरो से
1985
बताओ
actually.
सर, एरो से बताओ, एरो से बताओ.
एरो से बताओ. The blue shirt one or the corner white
The
shirt
blue-
one.
This is actually Dr. B.N. Chakraborty.
Which one are you?
And this is actually Dr. M.N. Parikh, 1985.
Yeah,
IVF
Hemant Parikh
laboratory
is
of
sitting
Jain
from
Chakraborty.
right, sitting
Yeah.
from left second. Yeah, with the white pant and the black jacket.
Yes,
White pant and black jacket, Dr. M.N. Parikh.
yes.
Yes, that we can
This
see.
is Dr. M.N. Parikh in 1985.
Yes, sir.
It is the IVF laboratory of Professor B.N. Chakraborty, and IUI was started in 1983 there. B.N. Chakraborty.
B.N.
I was
Chakraborty
the
बताओ ना.
junior most member of that team. I was the junior most member at that team. I witnessed how
The
IVF
right
developed.
Right side to Hemant Parikh, Mahendra Parikh is B.N. Chakraborty, right side.
Yes.
No,
Safar-
it is Dr. Subit Datta. Dr. Subit Datta who supplied the Hamceptin media and the distilled water and everything. And
Oh,
this
sir,
is B.N.
बताओ ना.
Chakraborty actually. And the
Chakraborty
left
sir
side,
बताओ.
extreme left side of the M.N. Parikh, extreme left, first row, B.N. Chakraborty.
Yes,
And
that
this
is
is
what.
Dr.
Oh.
Sudarshan Bhojdosidar. B.N. Chakraborty, S. Bhojdosidar and M.N. Parikh. And that's Dr. Subit Datta. And
That
this is
is what
Siddhartha
I'm
Chatterjee.
saying. Hmm.
Dr. Siddhartha Chatterjee. This is a very
Very nice.
historical photograph that I am showing with the permission of the office, permission of all of you. Dr. Lakshmi.
Sir, it was such a treasure you are holding.
I have taken a screenshot, sir. I have taken a screenshot.
I can send
Now
you.
that photograph is with me also.
This is a very history of IUI in India
I know.
from the very beginning. Dr. Ranjana, you see,
Yeah,
this
very
is
nice.
historical picture actually.
Very nice.
And
You are standing
it belongs
third
to
from
the profession of the ISAR.
Dr.
You
Arup.
imagine-
You are standing third from left.
Standing actually, there are some. Myself is the third person. Myself is third.
Third.
person,
That
junior
is what
most.
I'm saying.
I was at
I
that time
recognized
member
you
of-
even
I was at that time
No,
though
no,
you
member.
had
just
so
behind
much hair at
Hemant
that time.
Sir,
White
just
shirt,
behind,
Behind M.N.
just
Parikh.
behind
This is
M.N.
Dr.
Parikh is Dr. Arup.
Yes,
Huh?
yes.
Just behind M.N. Parikh is Dr. Arup.
Yeah.
Yes. I
And
agree.
if
I
you say
agree.
no, then you don't know how you used to look.
And
We
he is
are
Siddhartha
correct.
Chatterjee.
We are
actually,
correct.
Dr. Siddhartha Chatterjee.
Same. The looks are the
I will
same,
send
except,
you those who do
except
the
you,
ART in India.
sir, except you had more hair then.
Eh?
You had more hair on your head then.
Yeah, definitely.
But the looks are the same. The
Just
looks
after
are the same.
graduation, MBBS graduation, just after graduation.